Perinatal diagnosis. Professor Mahmoud Yosef Ali Ahmed Abdullah. Obstetrics Gynecology Department. Faculty of Medicine and Shams University. Perinatal diagnosis employs a variety of techniques to determine the health and condition of an unborn fetus. Perinatal diagnosis to assess health of fetus, growth, detect fetal pathology or anomaly and assess fetal well-being. Perinatal diagnosis to assess health of fetus, growth, detect fetal pathology or anomaly and assess fetal well-being. Perinatal diagnosis is helpful for managing the remaining weeks of the pregnancy, determining the outcome of the pregnancy, planning for possible complications with the birth process, planning for problems that may occur in the newborn infant, deciding whether to continue the pregnancy, finding conditions that may affect future pregnancies. The techniques employed for perinatal diagnosis. Non-invasive technique. Non-invasive technique. Ultrasonography, scanning, Doppler, CTG, biophysical profile. Fetal blood cells in maternal blood, maternal serum alpha-fetoprotein, maternal serum beta-HCG, maternal serum unconjugated estriol, pregnancy-associated plasma protein A, inhibin A. Invasive technique, amniocentesis, chorionic villus sampling, fetal blood sampling, ultrasonography. This is a non-invasive procedure that is harmless to both the fetus and the mother. High-frequency sound waves are utilized to produce visible images from the pattern of the echoes made by different tissues and organs, including the baby in the amniotic cavity. Pregnancy ultrasound purposes and uses. To determine pregnancy. To diagnose ectopic pregnancy. To diagnose pregnancy complications such as molar pregnancy and abortion. To check the growth and development of the fetus. To scan for congenital defects and genetic abnormalities. As part of other prenatal tests, such as chorionic villus sampling, amniocentesis and fetal blood sampling. Determine the size and position of the fetus. The size and position of the placenta. The amount of amniotic fluid. The appearance of fetal anatomy. Types of ultrasound probes. Linear probes allow for both 2D and 3D imaging. Convex ultrasound probes are for deeper organ imaging. Endocavitary probe, transvaginal probe. Phased array ultrasound probes are used for cardiac and transcranial examinations. Pencil ultrasound probes, also known as color wave Doppler probes, are typically used to measure blood flow and sound speed in blood. During early pregnancy, an abdominal transducer probe with a frequency of 5 MHz or a transvaginal transducer probe with a frequency of 5 to 10 MHz. Types of ultrasounds for pregnancy. Transvaginal scans. Standard ultrasound. Advanced ultrasound is ordered only when certain abnormalities are noted in the standard ultrasound. Doppler ultrasound is done to evaluate the blood flow of the fetus. 3D ultrasound produce three-dimensional pictures of the fetus. 4D ultrasound, also called a 3D dynamic ultrasound, this type of ultrasound for pregnancy, gives the most lifelike pictures of the baby. The transducers used in this technology are furthermore advanced and give a more realistic view of the baby. Fetal echocardiography is done to assess the heart and the anatomy of the baby. Assessment of fetal size and pregnancy dating. Early ultrasound examination at 8 to 14 weeks, based on measurement of the fetal crown rump length, CRL, appears to be the most reliable method to establish gestational age. Before 14 weeks, crown rump length, CRL, should be used to assess fetal size and to estimate gestational age. Once the CRL exceeds 84 mm, head circumference, HC, with or without femur length, FL, can be used for estimation of gestational age from the mid-trimester if a first trimester scan is not available and the menstrual history is unreliable. Standard fetal biometry. Sonographic measurements of A. Head circumference, HC, B. Abdominal circumference, AC, and C. Femur length, FL, Types of fetal growth restriction. It has been classified into early onset, detected before 32 weeks gestation, and late onset, detected after 32 weeks gestation, types. Screen for FGR and/or SGA fetuses. A routine mid-trimester ultrasound scan is typically performed between 18 and 22 weeks of gestation. Serial scans for interval growth are best performed at least 3 weeks after a preceding scan for detection of fetal growth restriction. Assessment of amniotic fluid. The two main methods for semi-quantitative evaluation of amniotic fluid are the deepest vertical pocket, DVP, and the amniotic fluid index, AFI. The deepest vertical pocket, DVP, must be at least 1 cm wide to be considered valid, except for biophysical profiles, where a 2 cm width is required. To calculate the amniotic fluid index, AFI, the uterus is divided into 4 quadrants using the umbilicus as the central point. The 4 measurements are added together to determine the total AFI. A normal deepest vertical pocket, DVP, ranges from 2 to 8 cm, with values 2 cm indicating oligohydramnios and greater than 8 cm indicating polyhydramnios. Polyhydramnios can be graded in severity using the following thresholds for amniotic fluid index, AFI, or deep volume pocket, DVP. AFI. Mild polyhydramnios 24 to 29.9 centimeters. Moderate polyhydramnios 30 to 34.9 centimeters. Severe polyhydramnios greater than or equal to 35 cm. DVP. Mild polyhydramnios 8 to 11 centimeters. Moderate polyhydramnios 12 to 15 centimeters. Severe polyhydramnios greater than 16 cm. Oligohydramnios is defined as a single deepest vertical pool, DVP, of 2 centimeters or less. It may also be described using the amniotic fluid index, AFI, of 50 millimeters or less. Ultrasound scan for placenta. Placental abnormalities. Abruptio placenta, premature separation of the placenta near term, with retroplacental blood clot. Placenta previa, low-lying implantation site can lead to hemorrhage during delivery. Velominous insertion, cord vessels splay out in the membranes before reaching the placental disc and predispose to traumatic rupture. Ultrasound scan for fetal anomalies. Abnormal nuchal translucency, NT, is associated with a higher rate of structural abnormalities in fetuses with normal and abnormal karyotypes. Abnormal NT at 11 to 14 weeks is an indication for genetic counseling, and early second trimester ultrasound at 14 to 16 weeks should be considered. Abnormal NT is also an indication for fetal echocardiography in the second trimester. In some cases, first trimester ultrasound findings may be suspicious, but not diagnostic, for abnormalities of certain structures. In these cases, early second trimester ultrasound can lead to prenatal diagnosis prior to the routine 18 to 20 week scan. In our experience, early second trimester ultrasound in such cases contributed to lower gestational age at abortion in women undergoing ultrasound at 11 to 14 weeks. Ventriculomegaly, whether isolated or with associated structural abnormalities, is associated with genetic abnormalities. Mild ventriculomegaly is associated with Down syndrome. Hydrocephalus in a male fetus with no associated finding could reflect a mutation in the L1CAM gene associated with X-linked hydrocephalus. Dandy-Walker malformation is associated with chromosomal abnormalities, as well as single gene disorders. While open neural tube defects are usually multifactorial in origin, they may be a feature of trisomy 18. Nuchal translucency. Hydrocephalus. 2D ultrasound image showing normal appearance of embryonic spine at 8 weeks gestation. 3D ultrasound image showing prominent myeloma meningoceal in embryo at 9 weeks gestation. Post-mortem image of fetus with open spina bifida at 10 weeks gestation. Anencephaly. The key features are: 1. Imperfect formation of the base of the skull. 2. Rachis. The spinal cord is exposed due to the failure of the posterior neuropore to close. 3. Exaggerated lordosis of the vertebral column. Encephalocele. Herniation of brain through a skull defect. Hydrops fetalis. Immune hydrops. Immune causes such as Rh incompatibility between mother and fetus. Non-immune. Congenital infections. Cardiac anomalies. Chromosomal abnormalities. Fetal neoplasms. Twin pregnancy. Fetal anemia. Other anomalies: pulmonary, renal, gastrointestinal. Typical hydropic ultrasound findings in fetuses with congenital parvovirus B19, skin edema and ascites, A. Cardiomegaly, pericardial effusion, and skin edema, B. And ascites, C. Disruptions. Some of these abnormalities may involve problems with vascular supply. The result is abnormal formation of a body region or regions. Such disruptions are generally asymmetric. Examples may include limb-body wall complex, amniotic band syndrome. This lateral abdominal wall defect is known as a gastroschisis. The umbilical cord is not involved, and the herniated abdominal contents are not covered by a sac. A gastroschisis suggests a limb-body wall complex, and a search should be made for amniotic bands. Sirenomelia. Persistence of the vitelline artery leads to abnormal aortic development with curtailment of blood flow to the lower extremities. Placenta showing blood vessels, anastomosis leading to feto-fetal transfusion syndrome. Polycystic kidney. 3D sonographic images with rendering mode showing conjoined twins at 7A and 8B weeks gestation. Maternal blood sampling. Maternal serum alpha-fetoprotein, MSAP. The MSAP test can be utilized to determine the levels of AFP from the fetus. Elevated MSAP in case of fetal defect in the body wall. Open neural tube defect. Omphalocele. Gastroschisis. The MSAP is typically reported as multiples of the median, MOM. The greater the MOM, the more likely a defect is present. The MSAP has the greatest sensitivity between 16 and 18 weeks gestation, but can still be useful between 15 and 22 weeks gestation. Using a combination of MSAP screening and ultrasonography, almost diagnose all cases of anencephaly, and most cases of spina bifida. Neural tube defects can be distinguished from other fetal defects, such as abdominal wall defects. If the acetylcholinesterase is elevated in amniotic fluid along with MSAP, then a neural tube defect is likely. If the acetylcholinesterase is not detectable, then some other fetal defect is suggested. The MSAP tends to be lower when trisomy 21 or other chromosomal abnormalities is present. Maternal serum beta-HCG. Useful early in pregnancy when threatened abortion or ectopic pregnancy is suspected, because the amount of beta-HCG will be lower than expected. Very high levels of HCG suggest trophoblastic disease, molar pregnancy. The absence of a fetus on ultrasonography along with an elevated HCG suggests a hydatidiform mole. Later in pregnancy, in the middle to late second trimester, the beta-HCG can be used in conjunction with the MSAF to screen for chromosomal abnormalities and Down syndrome. An elevated beta-HCG coupled with a decreased MSAF suggests Down syndrome. Maternal serum unconjugated estriol. The amount of unconjugated estriol in maternal serum is dependent upon a viable fetus, a properly functioning placenta, and maternal well-being. The substrate for estriol begins as dehydroepiandrosterone, DHEA, produced in the fetus. This is further metabolized in the placenta to estriol. The estriol crosses to the maternal circulation and is excreted by the maternal kidney in urine or by the maternal liver in the bile. The measurement of serial estriol levels in the third trimester will give an indication of general well-being of the fetus. Estriol tends to be lower when Down syndrome is present or when there is adrenal hypoplasia with anencephaly. Inhibin A. Dimeric inhibin A is secreted by the placenta and by the maternal ovarian corpus luteum. An increased level of inhibin A is associated with an increased risk for trisomy 21. Risk for preterm delivery. Triple or quadruple screen. The classic test is the triple screen for alpha-fetoprotein, MSAF, beta-HCG, and estriol, UE3. The quadruple screen adds inhibin A. Triple test. Neural tubal defect has high maternal serum alpha protein, normal unconjugated estriol and normal human chorionic gonadotrophin. Trisomy 21 has low maternal serum alpha protein, low unconjugated estriol and high human chorionic gonadotrophin. Trisomy 18 has low maternal serum alpha protein, low unconjugated estriol and low human chorionic gonadotrophin. Molar pregnancy has low maternal serum alpha protein, low unconjugated estriol and very high human chorionic gonadotrophin. Multiple gestation has high maternal serum alpha protein, normal unconjugated estriol and high human chorionic gonadotrophin. Fetal death, stillbirth, has high maternal serum alpha protein, low unconjugated estriol and low human chorionic gonadotrophin. Pregnancy-associated plasma protein A, PAPA. Low levels of PAPA during the first trimester may be associated with fetal chromosomal anomalies including trisomies 13, 18, and 21. Late in pregnancy. Low levels of PAPA may predict an adverse pregnancy outcome, including a small for gestational age, SGA, baby or stillbirth. A high PAPA level may predict a large for gestational age, LGA, baby. Maternal age and risk of trisomy. Approach to diagnosis of trisomy 21. In the first trimester, combined ultrasound screening with measurement of nuchal translucency, PAPA, and beta-HCG has a high diagnostic yield. Second trimester, quadruple screening with measurement of AFP, beta-HCG, unconjugated estriol, and inhibin. The detection rate of trisomy 21 for the triple screen is about 70%, and for the quad screen about 80%, with false positive rates of 7% and 6% respectively. Combining the quad screen from the second trimester with results of PAPA and NT from the first trimester yields a Down syndrome detection rate of 90%, with 3% false positive rate. Without the NT test, combination of the 5 serum tests yields a detection rate for trisomy 21 of 87% with 3.2% false positive rate. Maternal blood sampling for fetal DNA. Ordinarily, only a very small number of fetal cells or cell-free DNA enter the maternal circulation. The sequencing of maternal plasma cell-free DNA, cfDNA testing, can detect fetal autosomal aneuploidy. Fetal blood grouping using cell-free fetal DNA, cfDNA, from maternal plasma in alloimmunized pregnancies can be performed for detection of RHD, D, RHCE, CN/or E, or Kel*01, K. Fetal RHD typing using a high-throughput methodology in pregnant women who have not formed anti-D, as part of a screening program to target anti-DIG prophylaxis, is sufficiently accurate for implementation from 11 weeks gestation. Prenatal screening for thalassemia. ACOG recommends that women with a low mean corpuscular volume, MCV, should have serum ferritin assessment. Those with normal levels and microcytic anemia should have hemoglobin electrophoresis testing. 7 For patients with a normal hemoglobin electrophoresis and Asian ancestry, genetic testing for alpha thalassemia is recommended. Couples who are both identified as carriers should receive genetic counseling to determine risk of an affected fetus, and family decision support should be provided. The most severe form of alpha thalassemia, deletion of all 4 alpha genes, results in hydrops fetalis. Prenatal screening would identify the at-risk fetus, and amniocentesis or chorionic villus sampling would confirm the diagnosis. In a suspected pregnancy, Doppler assessments of cerebral vessel flow velocities or direct fetal blood sampling to quantify the anemia could be used. If intrauterine transfusions are instituted in time, such fetuses may survive but would be transfusion dependent. Postnatally designated alpha thalassemia major. Invasive procedures guided by ultrasound. Ultrasound, pre and post procedure. Before subjecting a woman to an invasive procedure, the following items should be checked by ultrasound. Number of fetuses and viability. Placental location. Amount of amniotic fluid. Gestational age. Ultrasound examination is also performed commonly after an invasive procedure to check the fetal heart rate, placenta, presence of hematoma, and amount of amniotic fluid. This can be done immediately or some days later. Karyotyping. Mosaicism. A mosaic is a person with a combination of 2 cell lines with different karyotypes, normal and abnormal. An example would be a Turner's mosaic, with a 45x/46xx karyotype, with some cells having the abnormal karyotype and some cells having a normal karyotype. Sometimes the mosaicism is confined to the placenta, confined placental mosaicism. A placenta with an abnormal karyotype, confined placental mosaicism, may lead to stillbirth, even though the fetus has a normal karyotype. Conversely, a placenta with a normal karyotype may allow longer survival for a fetus with a chromosomal abnormality. Full karyotype. The conventional method for karyotype analysis is metaphase analysis of cultured amniocytes or that of placental mesenchymal cells obtained from amniocentesis or CVS, respectively. The results are available in 2 weeks. Metaphase analysis of fetal lymphocytes obtained from chordocentesis is available in 2 to 5 days. Following CVS, direct analysis of cytotrophoblastic metaphases is feasible and may be achieved within 5 days. Rapid testing, such as qFPCR, or, more rarely, FISH, may be carried out on villi or amniotic fluid to test for specific chromosomes, 21, 13, 18, X, Y. These tests provide results in 1 to 2 days and are commonly employed following a screen-positive result or in fetuses with ultrasound findings or markers of common aneuploidies. The rhesus status of the mother and the presence of alloantibodies in the serum should be checked before performing a prenatal invasive procedure. Prophylactic anti-D immunoglobulin should be given to non-sensitized women within 72 post-procedure unless the alleged father of the fetus is proven also to be rhesus negative. Rhesus prophylaxis is strongly recommended after an invasive procedure in non-sensitized rhesus negative women with a rhesus positive partner, unless the fetus has been found to be rhesus negative by CFF DNA testing of maternal serum. A single intramuscular dose of anti-D antibodies in fixed preparation is commonly used. Human immunodeficiency virus, HIV. Amniocentesis was a major risk factor for vertical HIV transmission in the pre-antiretroviral drugs era. Amniocentesis. This is an invasive procedure in which a needle is passed through the mother's lower abdomen into the amniotic cavity inside the uterus. For prenatal diagnosis, most amniocentesis are performed between 15 and 20 weeks gestation. However, an ultrasound examination always precedes amniocentesis in order to determine gestational age, the position of the fetus and placenta, and determine if enough amniotic. The amniotic fluid are fetal cells, mostly derived from fetal skin, which can be /grown in culture for chromosome analysis, biochemical analysis, and molecular biologic analysis. In the third trimester of pregnancy, the amniotic fluid can be analyzed for determination of fetal lung maturity. The amniotic fluid can be analyzed by looking for an appropriate number of lamellar bodies. Other tests for fetal lung maturity include fluorescence polarization, FPOL, lecithin, sphingomyelin, LS, ratio, and for phosphatidylglycerol, PG. Risks with amniocentesis are uncommon. Fetal loss and maternal Rh sensitization. The increased risk for fetal mortality following amniocentesis is about 0.5% above what would normally be expected. Rh-negative mothers can be treated with RhoGAM. Chorionic villus sampling, CVS. CVS is the withdrawal of trophoblastic cells from the placenta. This procedure was first described in China in the mid-1970s and introduced into clinical practice in the early 1980s. Chorionic villus sampling, CVS, should be performed after 10+0 gestational weeks. CVS can be performed transabdominally or transcervically, according to the operator's experience, preference, or placental location. The fetal loss rate after transcervical CVS was reported to be 2.5%. Vaginal bleeding is reported to occur in 10% of cases. Fetal blood sampling, FBS. FBS should be performed transabdominally after 18+0 weeks, using a 20-22G needle under ultrasound guidance. The most common indications for FBS are investigation of chromosomal mosaicism after amniocentesis and hematological assessment of the fetus. The term chordocentesis refers to the ultrasound-guided puncture of the umbilical cord, umbilical vein, for either diagnostic, FBS, or therapeutic, intrauterine transfusion or drug instillation, purposes. The first series describing experience with FBS was published in 1987. A 20-22G needle is introduced transabdominally under continuous ultrasound guidance and inserted into the umbilical vein. The freehand technique is used more commonly, although the use of a needle guide is preferred by some. Assessment of fetal well-being. Fetal cardiotocography, CTG. When using the FIGO score for the assessment of CTG readings, a reading of 30 minutes is necessary. The duration of the reading should be prolonged if the FHR pattern looks suspicious. A reduction of reading times to 10 minutes is possible with certain analysis methods. The maximum time for an Oxford CTG is 60 minutes. Normal CTG, heart rate, 110 to 160 BPM, beat-to-beat variability equal or more than 5, no deceleration, fetal heart acceleration is present or sporadic. Suspicious CTG, heart rate, 100 to 109 or 161 to 180 BPM, beat-to-beat variability less than 5 or 2/40 minutes, early or individual prolonged deceleration for 3 minutes, fetal heart acceleration present or periodical occurrence with each contraction. Pathological CTG, heart rate less than 100 or more than 180 BPM or sinusoidal, beat-to-beat variability less than 5 BPM over more than 90 minutes, atypical variable deceleration or prolonged deceleration for 3 minutes, absent acceleration over 40 minutes. 1 FHR deceleration amplitude greater than or equal to 15 BPM, duration greater than or equal to 15 seconds. 2 FHR acceleration amplitude greater than or equal to 15 BPM, duration greater than or equal to 15 seconds. 3 sinusoidal FHR, greater than or equal to 10 BPM, duration greater than or equal to 10 minutes. Automated measurement of short-term variability, STV. 26 to 28 weeks is more than 2.6 milliseconds. 29 to 31 weeks is more than 3 milliseconds. 32 to 34 weeks is more than 3.5 milliseconds. 34 to 36 weeks is more than 4.5 milliseconds. Types of fetal deceleration. A typical or an uncomplicated variable deceleration has 4 components. Initially, there is a slight rise in the FHR, shouldering, followed by a sharp fall from the baseline, 60 bpm, with a quick rise that gives a second shouldering and a final recovery to the baseline. They last for 60 s. An atypical variable deceleration does not have the features of the typical deceleration described earlier. The initial and final shouldering disappear. Drop in the FHR of greater than 60 bpm may denote the complete occlusion of the umbilical cord, and the recovery to the original baseline may be delayed. If these decelerations are recurrent, there may be a component of acidosis with time. Repetitive variable or late decelerations lasting for 50% of contractions greater than 30 minutes as pathological. Increased variability greater than 25 bpm is for 10 minutes is suspicious, and greater than 25 bpm for greater than 30 minutes pathological. Increased variability greater than 25 bpm, the zigzag pattern, is associated with a rapidly evolving hypoxia, example injudicious use of oxytocics or active maternal pushing. Scientific evidence have shown that zigzag pattern, which lasts for more than 2 minutes, has been shown to be associated with poor perinatal outcomes and approximately 11-fold increase in the admission to the neonatal unit. Ultrasound Doppler. Uterine artery Doppler is a non-invasive ultrasound test used during pregnancy to assess blood flow in the uterine arteries. It helps in detecting any alterations in blood flow that may indicate impaired placentation, which can affect the health of both the mother and the baby. The test typically measures the resistance of blood flow in the uterine arteries, which decreases as the pregnancy progresses. It is usually performed during routine ultrasound scans. This assessment is crucial for monitoring the health of the placenta and ensuring adequate blood supply to the fetus. 2. Overall, uterine artery Doppler is an important tool in prenatal care to help identify potential complications early on pregnancy. Uterine artery Doppler is a promising tool for predicting development of preeclampsia by analyzing both pi, more than 1.7, as well as presence of diastolic notch in uterine artery. Doppler had high overall diagnostic accuracy for preeclampsia. Fetal Doppler. Mid-cerebral artery, MCA, Doppler seems to guide monitoring before 32 weeks of gestation, but there is no evidence that it should be used to determine delivery timing. Reduced fetal MCA pi is a consequence of vasodilatation, the so-called brain-sparing effect. This represents a hemodynamic response to fetal hypoxemia, via direct vascular sensing of oxygen tension in the cerebral circuit, and in other vascular beds a consequent redistribution of fetal cardiac output occurs preferentially to the coronary arteries and adrenal glands. The mean MCA peak systolic velocity for fetus with the normal hemoglobin, HB, was 48.98 plus or minus 13.94%, while that for the anemic fetus was 64.79 plus or minus 11.97%. Umbilical artery Doppler. Progressively increasing pulsatile index, pi, in the UA corresponds to a progressive reduction in the placental surface area available for gas and nutrient exchange and increased fetal afterload resistance, and is associated with placental vascular insufficiency reflected by absent and, in the end-stage phase, reversed end diastolic flow, EDF, in the UA. Ductus venosus Doppler. Alterations in the ductus venosus flow velocity waveform, especially absent or reversed A wave, are caused by progressive dilatation of the ductus venosus isthmus in order to increase the blood flow toward the heart, in an attempt to compensate for extreme oxygen deprivation. Biophysical profile. The biophysical profile has 4 sonographic components, each of which must be observed within 30 minutes of starting the ultrasound. Fetal breathing, 2 continuous movement of the fetal diaphragm for at least 30 seconds. Fetal movement, at least 3 discrete movements of the fetal body or limbs. Fetal tone, at least 1 active extension of a fetal limb with the return to flexion or opening and closing of the fetal hand. Amniotic fluid volume, a single deepest pocket of at least 2 centimeters. Biophysical profile scoring with fetal pH. The BPP score consists of the combined evaluation of fetal tone, gross body movement, breathing movement, amniotic fluid volume and heart rate reactivity. BPP score can predict both fetal pH and outcome. A score of less than or equal to 4 is associated with a fetal pH less than or equal to 7.20, while a score of 2 has a sensitivity of 100% for acidemia. The loss of fetal gross body movement in association with ductus venosus Doppler index alterations can predict fetal cord pH 7.20, while loss of fetal tone is associated with pH 7.00 or a base excess 12 milliequivalent/L. MCA Doppler is one of the first parameters that becomes abnormal in early FGR. There seems to be a weak association between low MCA pi and adverse short-term neonatal outcome and between low MCA pi and high UCR and 2-year adverse neurodevelopmental outcome 52. However, gestational age at delivery and birth weight have the most pronounced impact on these outcomes 52. Thus, MCA Doppler seems to guide monitoring before 32 weeks of gestation, but there is no evidence that it should be used to determine delivery timing. Fetal scalp blood sampling during labor. In case of persistent fetal heart deceleration during labor. Fetal scalp blood sampling pH measurement. If fetal blood pH greater than or equal to 7.25, if FHR abnormality persists, FBA should be repeated after an interval of 30 minutes. If fetal blood pH 7.21 to 7.24, FBA should be repeated after an interval of 30 minutes, or rapid delivery of the fetus should be considered, if pH value has dropped quickly since the last measurement. If fetal blood pH less than or equal to 7.20 pCO2 65 mmHg, acidosis, B9.8, e.g. 15 mol/L, metabolic acidosis, quick delivery of the fetus is indicated, particularly if metabolic acidosis is present. Thank you.